To understand what brain spotting does to the brain, we need to understand how the brain works. And in general terms, it's a graph that shows something called perfusion. And perfusion refers to blood flow to the brain. So anytime you're engaged on a task, mathematical task, or looking at a picture, or listening to somebody talk to you, whatever it is that you're engaged in doing, your brain needs to have some level of blood perfusion. So your brain needs to get blood flow to that region for it to work well. And one of the hypotheses that I have is that if we can optimize perfusion, people will benefit a lot more greatly from the brain spotting experience. Trauma, emotional trauma, psychological trauma is related to poor perfusion, or what we call hypoperfusion. So when somebody's being emotionally, psychologically, or even physically traumatized, the brain will activate certain networks that work as a protective shield. And they will not allow certain information to flow through those networks. And that has to do with poor perfusion. So people who experience a hard time healing from their trauma might partly be experiencing that because their brains are not optimally getting enough blood and enough oxygen to work at a level that allows the client to heal. And so we can measure that level of perfusion and relate it to brain waves. Because I work with the EEG, I work with frequency bands or brain waves, which is really, in layman's terms, electrical activity in the brain. So you probably have heard about alpha brain waves, delta brain waves, gamma brain waves, beta brain waves, and so on and so forth. And those are related to perfusion. So when we talk about delta brain waves, first of all, we have a 0 here, which is optimal perfusion. And here we have 1, 2, and 3 standard deviations above that, and then 1, 2, 3, and 4 standard deviations below that. So anything that's above the 0 is going to be hyperperfusion or getting too much blood flow. So there's such a thing as the brain getting excessive blood flow or deficient blood flow. And if we're in the delta brainwave range, we're going to have hyperperfusion. And if we are in here 14 to 40 hertz, it's going to be in the alpha to gamma range. So alpha brainwaves, beta brainwaves, theta brainwaves, and mu brainwaves are going to correlate with hyperperfusion. Normally, when I work with somebody, if I'm going to do brain spotting, I like to record a baseline EEG. And what that means is I record their brain activity at rest. They're just sitting there, relaxing, not doing anything in particular, not engaged in any type of task. And that lets me see where their perfusion is. Because perfusion is going to be related to arousal. So I want to see whether the client is hyper aroused, they're hyper vigilant, they're angry, they're scared, they're anxious most of the time, or if they're hypoperfused or hypo aroused. And that means that they are dissociating, they're experiencing low motivation, trouble initiating action, they feel depressed, they feel tired all the time. So blood perfusion will provide us with very valuable information as to the client's arousal. And then we can gauge whether we can change that through brain spotting, or at least partly through brain spotting. And I'm going to show you a couple of EEGs later on that could show that that indeed is the case. So we always aim for something called neutral positive perfusion, which is what you see in the middle here. And neutral positive perfusion means the brain is getting the right amount of oxygen and the right amount of blood at the right moment in time. Not a lot, not deficient, just the right type. And I do believe that that we can achieve that with brain spotting. That maybe not fully, but it's one of the tools that we'll have that will permit us to do so. So understanding perfusion is important. I want to know whether my client is hypervigilant or not hypervigilant, or hypovigilant, or they dissociate as this most salient tendency, or if they experience mostly anger, or if they experience resentment, and what drives that sensation, and how we can switch that more optimally for healing to take place. Now, we also have to think brain networks. We cannot talk about brain spotting, the brain and the EEG, without talking about networks. And when we work with brain spotting, we're going to be influencing different brain networks. The main one is what we call the default mode network. Okay, and the default mode network is the network of the brain that is active when we're not doing anything. So what are we thinking when we're not really thinking? If you lay down in bed and you're looking at the roof, at the ceiling on your house, and you're not thinking about anything in particular, that's your default mode network. So the default mode network really is your brain at rest. Okay. And that means your brain is neutral, is ready to respond. And in trauma, we can sometimes have a very strong impact, or a very dramatic impact on the default mode network, meaning some people get stuck in the default mode network and they cannot shift gears. So if you think of driving a car, and it's a manual transmission, not an automatic, but a manual transmission that has a stick shift. Sometimes you would notice that if you ever drove one of those, sometimes the stick shift would get stuck and you could not shift gears. And that's what the default mode network does. It allows you to shift gears and go into action depending on what you need to do. But sometimes when people are deeply traumatized, the default mode network becomes the norm, and it does not allow other networks of the brain to become active. Therefore, the person is not able to heal optimally, because they cannot use the salience network or the negative effect network or the other networks of the brain. So one of the most affected networks of the brain is going to be the default mode network. And that in the EEG, that will show as something called kurtosis of the alpha rhythm. So I'm going to throw a couple of technical terms that I will try to succinctly explain. And what kurtosis means is that there's no flexibility in the central nervous system. One of the first things that trauma impacts is the ability for the central nervous system to be flexible and change activity. Therefore, that's why a client feels stuck in dissociation, in hypervigilance, in anger, in sadness, because the insult to the brain is so strong. The brain protects itself by not allowing information to flow freely and efficiently. And let me say, I think there might be a question or questions in the chat. Oh, some comments. Okay. So the default mode network, it's important. We need it when we're at rest. Now, it can also happen that the salience network, it might be more dominant or more salient in its activity. The brain is a prediction organ, and the brain is also a filter organ. What that means is that we're constantly bombarded with stimuli from our worlds, our families, our work, the news, noises, everything that happens in the environment is constantly bombarding the brain. And the salience network is the filter that allows us to determine what is relevant and what's not relevant. So I believe there's a question. Somebody open their mic. Great. So I believe somebody opened their mic. Please check that you muted. Thank you. So the salience network will help us determine
what do you want
if
be gone.
Now, I think your mic's open.
Okay. We will turn off the mic from the back end. Sorry for the interruption.
That's okay. Sometimes people will key their mics accidentally. So the salience network, again, we determine whether that's salient or not. So let's say I'm walking down the street and I hear a car suddenly braking and I hear the tires screeching. Well, I'm going to turn around. I'm going to see where the noise is coming from. Now, my salience network is going to determine whether I need to react to it or not. If I see the car is coming towards me, well, the salience network is going to say, well, you better move out of the way or you're going to get run off. And then I act upon it. But if I see that the car is screeching because a dog or somebody was crossing the highway and they had to suddenly brake, and I don't need much more reaction than that, then I move on. So every time something happens, the brain decides within a few milliseconds whether that's important to react to or not. And then we move on. Now, we can have people with trauma whose negative affect network is mostly salient. And that these are the people who are stuck in anger, in depression, and anxiety, negative emotions and negative cognitions. Negative emotions and negative cognitions and negative physical reactions rule and dominate this person's world on a daily basis. And that is, their negative affect network is much more salient. Now, before I continue to the other ones, you will notice that there are areas and regions that overlap in the networks. One of them is the anterior medial prefrontal cortex, or rather the anterior cingulate cortex. And the limbic system, the hippocampus and amygdala, are going to be part of that overlapping of networks too. So if you see, the anterior cingulate cortex is very much part of all the networks, and the insula, the amygdala, and some other areas also overlap. Therefore, it is no surprise to see that trauma affects people in different ways, and sometimes trauma will affect people in similar ways. It all depends on where the impact is felt the most in those networks of the brain. And it also will depend on the person's genetics and if they had any previous trauma history and characteristics of their life at the moment of the trauma. Now, you've probably heard David mention that Brainspotting is a neuro-experiential process, it's a neuro-experiential experience, right? And he's absolutely right. It's neuro-experiential because we're targeting neurophysiological and psychophysiological systems that allow us to process trauma in different ways when we're doing brain spotting. And those brain networks are going to be involved in that. Now, the positive affect network is usually one of the ones that's hindered the most. Trauma will inhibit the ability for people to feel joy, happiness, peace of mind. And therefore is one of those networks of the brain that is mostly highly impacted, but also is one of those networks of the brain that opens up nicely when we are healing, and specifically through brain spotting. One of the interests that I have in my line of research and work, and that I would say we, because now my friends and colleagues in Singapore are highly involved in this, is that we want to see whether different different brain spotting setups will have an impact on different networks. What I mean by that is that from the EEG perspective, I would love to see whether inside window is more beneficial than outside window for some people, or that Z-axis might be more beneficial, or gaze spotting might be more beneficial. That's not to say that the other setups are not beneficial, but I do believe that there are people who will better respond to some specific setups, or whether doing activation spot versus a research spot works better for many people. And we know we have our work cut out for us, but we'll get there sometime. Time is something that I certainly have right now. So we're working to be able to determine how the brain responds to brain spotting and what the brain can tell us about brain spotting and its intricacies. Now, the attention network, it's very closely related to the salience network in that we pay attention to something we find relevant. The problem is that with trauma, we tend to direct our attention to the wrong stimuli, the wrong cognition, the wrong emotion, or the wrong physical sensation. And again, because the trauma is so impactful, the brain will develop a way to pay attention to that. Ironically, the brain is going to hold on to the trauma, knowing that it's not a good thing to do so. But ironically, some networks of the brain will hold on to it. And again, it doesn't take long-term continuous trauma. This can be short-lived, very impactful, very intense trauma to activate those networks of the brain. So those of us who witnessed 9/11 either on TV or live, I have some colleagues who witnessed the second plane hit the towers, and obviously their experience is much different than mine. I saw it on TV, and there's specific brain networks for them that are going to be more salient and different from other people who were there that day and witnessed the events as they unfolded.
Hi, Santiago, we've got a comment in the comment box from Cheryl N, and she says, I can see that knowing how to target the salience and attention networks would be especially helpful with ADHD clients. Would you like to respond to that?
Yes, absolutely. That's a very good comment, and that's spot on in that ADHD and ADD are usually misinterpreted as a lack of attention or a failure of paying attention. When in reality, many times ADD, ADHD is not knowing what to pay attention to. What I see in the EEG of people who have been diagnosed with ADD or ADHD is that the salience network does not know how to filter events. So every single thought, every single stimuli, it's important to the brain. The brain does not compartmentalize. It just receives the information and tries to process it at the same time. So yes, targeting both those networks with brain spotting, it's very useful. It's quite useful. And not only those who might have a confirmed diagnosis, for lack of a better word, for ADHD is anything that's attention related or anything that's stimuli filtering related.
Santiago, I have a question.
Yes.
So for people who have trauma and their salience network is affected, how does that look like?
Well, I'll show you an EEG of that, but in essence, what you see is somebody who has a tendency to present a specific brainwave pattern over the others, normally in the alpha range. The alpha range, and in the alpha range, because alpha brainwaves are produced by the thalamus. In brain spotting, we work with the subcortical brain. We help the client reach their subcortical brain for as long as we can. And the window that allows us to see, or the window that allows the subcortical brain to the cortical brain communicate efficiently is the thalamus. So the thalamus is the region that allows the subcortical brain and the cortical brain to communicate efficiently. And in trauma, the thalamus can be shut down. That's when you get a lot of default mode network hyperactivation or overactivation. And that means that the thalamus is not working the way it's supposed to. The thalamus is an oscillator. It will oscillate in different frequencies, normally from 8 to 12 hertz. And when it's not oscillating, it means that the brain does not have the capacity to shift gears again. And what happens? It ends up you end up experiencing kurtosis of the alpha rhythm. And as a matter of fact, since you're asking the question, I'm going to stop sharing my screen and I'm going to procure that EEG so that you can see what it looks like in the brain.
I'm actually asking about the salience network, not so much about the default. So
okay.
The default, you say that they feel stuck and people can get stuck because they're in the rest mode, they're neutral. What if they're stuck in the salience mode? So is that like hypervigilance? Is that similar to hypervigilance, or
yes.
the fight and flight mode that
Yeah, that is correct. Let me show you the salience, and then I'll show you the default mode, and I'll show you the salience. But yes, it's more hypervigilant, more prone to anxiety, rumination, and fretting are very common. So the anterior cingulate cortex is very, very active. And it's because it's receiving input from the amygdala and the hippocampus. The amygdala is over-aroused and the hippocampus is over-aroused.
Okay.
And those neurons are firing more than we really want to.
Okay, gracias.
De nada. All right, so let me share my screen. So this is an EEG of an athlete. This is a professional volleyball player that she was part of the national team. I saw her a few years ago. And she came to me for consulting for depression, but she had trauma history. I don't remember right now specifically what trauma, but I'm going to show you what it looks like on the color-coded images. So she's got some new brain waves that relate to trauma, but what it looks like, and I think I have to. Are you seeing the screen? Are you seeing the peaks?
Yep, we see the screen.
Okay, great. Can you see yellow peaks?
Yellow.
Yeah, thank you. So this is somebody with the four mode network overactivation. The yellow peaks show the alpha brainwaves. And this is the region known as PZ, which is the parietal region in the middle of the head. So if you go to the back of the head and touch your parietal lobe right in the middle, that is exactly the region we're talking about. And normally the base of the yellow peaks needs to be wider. When it's narrow like this, we call it kurtosis of the alpha rhythm. And kurtosis of the alpha rhythm means this person is stuck in the default mode network. So this is a brain that is not available or capable of shifting gears. And that's when they come to see us for Brainspotting, because psychotherapy hasn't worked for them and other interventions have not worked for them. Now, that's not to say that the other interventions are not efficient. That's to say that we need to focus on brain-based approaches. And this is where David and Robbie and Nancy and Pi and other trainers of mine mentioned brain-based approaches, is that because they're right. We cannot help somebody through just psychotherapy if the central nervous system is this inflexible. We cannot help somebody if their central nervous system is not flexible. And they're stuck in default mode network. They can try as much as they can, but they're not going to get better. Now, I did not know Brainspotting at this point when I worked with her. Otherwise, I would have done some work and recorded the EEG again. I did neurofeedback, and it worked very well for her. I think Brainspotting would have worked nicely, but again, I didn't have the chance. However, I'll show you another case of somebody who's stuck in hypervigilance or the salience network. Now, that's default mode network. The EEG, I'm going to open another EEG that is the opposite. That is hypervigilance. And it's salience network hyperactivation. And I'm going to go share my screen again. All right, so in this case, normally the brain does make two types of brain. So let me do some horrible drawings here. Brainwaves have amplitudes and they have frequencies. The larger a brainwave is, the slower it is. And the smaller the brainwave, or the smaller the brainwaves are, the faster they are. Okay, so bigger, smaller, bigger, slower, smaller, faster. And when we look at this EEG, we have dominance of fast brainwave activity. So this is an EEG that's dominated by beta brainwaves. These are beta brainwaves. These are beta brainwaves. These are beta brainwaves. Okay, so that's what we see in terms of dominance of EEG. And I'm sorry, I didn't get the name of the person who was asking the question about salience, but in some EEGs, not all EEGs, but in some EEGs, this is what it looks like. It's dominated by low amplitude, fast frequency brainwaves. This is somebody who has a tendency to be angry and anxious, and they fret and they dwell, and it's hard for them to let go of the past. And they wake up several times at night, and they experience the flashbacks, and every single stimuli, no matter how trivial it seems, it takes them back to the trauma. Okay, so this is somebody who has a lot of activation coming from the limbic system. This is amygdala overload, and the hippocampus is it's overloaded as well with information. And I'm going to show you what it looks like on the inside of the brain. So just gonna create some maps. Here. So I'm gonna create some images that look at the subcortical brain, and through brain mapping we can look at the generators, and the generators is the regions of the brain that might be related to that. We have here. Are you able to see the maps? I'm looking at some color-coded maps, so I just want to make sure that you can see them. All right, so I'm gonna choose this one because this one is showing that it apparently has an anterior cingulate cortex source. The red indicates that region of the brain we have to pay attention to, and I'm gonna create the image for that. I know that I have to change my sharing so we can see it. So, stop sharing. And here we are. So I think you can see it now. It's the same brain from 3 different angles. This is looking at it from above. This is looking at the inside of the right hemisphere, and this is looking at it from behind. So if you cannot see, please let me know. And if you can see, this is the anterior cingulate cortex right here. The red indicates the region of the brain that it's active and we need to pay attention to. So this is salience network. It's at least impacting the anterior cingulate cortex. Now, what I'm going to do is I'm going to scale that, meaning I'm going to see if other areas are going to light up in red. And you can start seeing that there are regions specific to the salience network, the insula, the amygdala, in this case, more on the left side, are engaged. Okay, so here we have somebody with limbic system hyperactivation, and this is salience network hyperactivation. So we can visualize it. Now, I know you're saying, well, that's very pretty, but what's the relevance of Brainspotting in this? Well, the next phase of the work is to record a baseline EEG, and that means we look at the brain at rest. Then we can look at the brain what the brain is doing as we are brain spotting the person, and then once the brain spotting session has taken place. But just to show you, this is what typically and Sellin's network EEG looks like. So Sellin's network or hyperactivated Sellin's network brain looks like. Now, we have the anterior cingulate cortex here. And again, I'm going to do some drawings here. And here we go. Oops. I'm able to get the pencil. There we go. Amygdala and hippocampus would be somewhere around this region. And what we're seeing in the anterior cingulate cortex is the neurons coming from the hippocampus and the amygdala projecting outward. So that's the information we're seeing. We cannot read amygdala and hippocampus from the EEG. They're too deep in the brain and they're monopoles. Monopoles meaning the electricity is concentrated within the structures. Okay. So what we do is we look at the interneurons, and there are different types of interneurons communicating the amygdala and hippocampus to the anterior cingulate cortex. But because there's pathways, here we have the pointer. The person is fixing their eyes on the pointer, and we're therefore targeting those pathways in different ways. I don't know, in all honesty, if we're going to be able to know soon or sooner or later the pathways involved. But I think that by understanding their underlying mechanism, I think we will. Now, remember that I said we have this is the visual field. We have the brain spotted with the pointer, person is looking at the pointer, and we go through the visual field. Now, we're gonna get to the anterior cingulate cortex. We're gonna get to the hippocampus and the amygdala, and somewhere over here is the thalamus. We're gonna get to the lateral geniculate nucleus of the thalamus into two types of visual fields, dorsal and ventral. Dorsal will process a specific type of traumatic memories. Ventral will process a different type of traumatic memory. At this point, we go into the tail of the comet because the brain will take over. The brain will do a sweep of the information and determine whether it's the ventral region of the visual field that needs to deal with the memory, or the dorsal region that needs to deal with that memory. And we start seeing the reflexes, and we start seeing the reaction from the client. This is also helped from the standpoint of the practitioner. So we have the practitioners, and I'm not a very good drawer, so I'm just going to draw a stick figure. This is the practitioner here, and we're helping that through the dual attunement process. Their amygdala and their amygdala are going to sync up at some point. And then we start seeing this beautiful, exquisite interaction in the human brain as part of the Brainspotting experience. With the technology we have now, we can measure that and measure those changes. And that's what I want to show you next. I think somebody was raising their hands. So if you have a question, please go ahead.
We have a comment. In fact, two comments. Sorry, Gloria, didn't see your earlier comment. Gloria asked earlier about autism. How does, I think it's in relation to Cheryl Ann's earlier question. Gloria was asking about autism. And then we've got another question from Hu Yusuf, who's asking about trauma. Is it true that by using this neurofeedback, they could map out past and present trauma?
Well, to the second question, I don't know precisely what is the case with that. I've been reading some of the, well, I have read the headlines to the news for that research. I haven't read the research really. it would not surprise me if somebody out there has come up with the capacity to scan a brain and locate past trauma in the brain and portray it by means of brainwave activity. I think that probably that's already happening. And if it is not happening, I would not be surprised to see that that is quite close. And I think that the work that we do in EEG and neuroscience, it's quite important to the work that we do in Brainspotting. But the same thing happens the other way around. Work that is done in Brainspotting has taught us a lot to develop better neuroscience research protocols. So I never saw the EEG work or neurofeedback and Brainspotting as being antagonistic. I think they complement each other very, very well. Both have their virtues and both have their limitations. However, I think that a combination of the two, at least that's what I do, works very, very well. And again, I'm not 100% sure, but I think they're close to it if they haven't done it by now, if they haven't been able to really map past traumas through EEG work at this point, or at least what we think is past traumas. I don't know what the comment was about autism, or if there was a question about it.
Laura, would you like to ask your question about in relation to autism?
Yeah, it is in relation to just now. There's another question on the ADHD and ADHD, right? Yeah. So I was just wondering, what about with clients with autism? Because it is probably I don't know, it's part of neurological difficulty in some sense.
Okay, well, I have not used Brainspotting in autism with clients who would be on the spectrum, so I can't work or not for autism in that regard. In the EEG world or in the neurofeedback world, there's been some reports of, and some research shows that neurofeedback does work well with specific population that is located, or that rather places at a specific point in the spectrum. The problem mostly with autism is that it's an overstimulation problem, and there's an overload of gamma brain waves. People in the spectrum, we've seen they tend to make much more gamma brain waves than we need to, and that provides for sensory and perceptual overload. And that's why some of the kids here are sensitive to touch. That's why some of them do not make visual contact or are nonverbal. And what we try to do with neurofeedback is train that brain to reduce the presence of the gamma brainwaves to the point that we can balance the brain out. Neurofeedback doesn't work for everyone. I don't think Brainspotting works for everyone. But in the cases that it works, I think it's highly efficient. I think that Brainspotting to some degree might help reduce the sensory and perceptual overload. What we would need to see, or what we would need to rather do, is to record the EEG and see what the mechanism is like. And that way we can point to seeing why it might be useful. My invitation is because I know there are more colleagues out there who are doing neurofeedback and EEG work, that they take on some of the research that it's being done, and that we can pull together and start providing with more evidence. If at any point I have not answered your question satisfactorily, please let me know. To your satisfaction, please let me know.
Thank you. That's informative. Thanks.
So again, we have this is a salience network overload and hyperactivation, and that is one of the features of salience network, and you could see also one of the features of default network hyperactivation. Now let's look at some actual brain spotting pre and post activity. So what I'm going to do is I'm going to open some files here. And just bear with me for a second, please. All right, so let's do, we have two males. This is baseline and this is after brain spotting. So I'm going to open the EEG for the baseline first. Well, actually, it should be the other way around because then I don't have to switch them. So open file, that was brain spotting, and baseline. All right, so I think you can see that I have two EEGs side by side. To the left, we have the EEG of one of the persons, of the individuals who were recorded with Deb Antinori and Supinko in New York. And to the right, we have the same person. This is baseline at rest, not doing anything with the eyes open. And this is after we finish their brain spotting session. Now, I want to point your attention because there's some relevant activity here. So I want to direct your attention to this activity right here. This is coming from the T3 region, which is the left temporal lobe. And this is called a slow transient. Okay, it's relevant. It's called a slow transient. It's coming from T3 and then the T5 region. So it's the left temporal lobe. And I'm going to show you the pre and then I'm going to show you the post. Now, when I see a slow transient, I start suspecting something structural going on in the brain. Okay, a brain tumor, a lesion, the residuals of a traumatic brain injury. A lot of clients who have had traumatic brain injuries will have slow transients. And a transient means it's not happening here, then it happens here, and then it goes away. All right, so now you see me, now you don't. And I'm going to fast forward to show you it happens several times. There it is again, and there it is again, and there it is again. So this person has a left slow transient, and that's ischemic in nature. You can see it better here. Look at the size of the brain waves coming from the left temporal region. That's the most salient presentation. And the reason I'm pointing to it is because it's quite present and it's ischemic. Ischemic means when this happens, the brain is not getting enough blood flow and enough oxygen to that region of the brain for however long it lasts. Then after the brain spotting session, it doesn't completely go away, but it's not as present as it was before. This is the same time frame, 39 seconds. I'm going to isolate it so you can see it. And 39 seconds here, it's not there. Look at the difference between this and this. So it seems to me that brain spotting, when we were talking about perfusion at the beginning of the presentation, it seems to me that brain spotting does indeed influence perfusion in a positive way. This is hypoperfusion, and this is neutral positive perfusion. And again, very slow and much better. So can we tell whether it was brain spotting? Not with 100% certainty, but I think it did have an influence. So to understand it a little better, I'm going to show you the graphs. So I'm going to make the maps for the baseline first, because the color-coded peaks help us understand it better. All right. So this is the transient. Left temporal lobe. Look at how high the alpha is. The peak, the yellow peak is the alpha brainwaves. Now let's look at it after brain spotting. So this is the same scale, 1.5 microvolts and 1.5 microvolts. I'm going to draw on it so you can see it. This is before, and this is after. This is not the effect of medication. We didn't do any neurofeedback. This is after a 45-minute brain spotting session. We recorded the baseline. The session took place, the brain spotting session was 45 minutes long, and then after 45 minutes, this is what we get. Okay, so this person is not taking any medication. They were not on any kind of other intervention. This is after 45 minutes of brain spotting. Now,
Angela has a question, Santiago. She asked, do you remember what setup you used for that session?
If memory doesn't fail me, I think it was inside window. I could be wrong. I would have to look at the notes, but I'm almost certain it was inside window. I don't remember what the issue was, but I think it was, yeah, I'm almost certain it was inside window.
Magda has a follow-up question. How long did the change last?
Well, that's a very, very good question. And we did not have enough time to measure how long it lasted. We know this is only after the brain spotting session. And the reason being that this was not, we were not getting any funding for the research. I flew to New York out of my own pocket, and I stayed out of my own pocket. I wish I could have stayed for longer to do it, to do some kind of follow-up. And that's a very good question, because we need funding for research, and we need to have funding for follow-up research. You know, we need to see if this was a one-off or whether the gains are going to sustain. I believe they will sustain, but we need to do the measurements. Now, here's the transient in red, and here it's gone after 45 minutes. So this is hypoperfusion, and this is neutral positive perfusion. Okay, so a little bit on the right side too, but mostly on the left temporal lobe, and then it's gone after 45 minutes. So was there perfusion, neutral positive perfusion taking place? Yes, we can see it here in the maps, but we could also see it in the EEG. How long does it last? I don't know. I really don't know. I'm sorry to say. It's something we need to analyze with more profound, long-lasting, better funded research.
Can I ask a question, please?
Yes, of course. Please go ahead.
Sorry. I was just wondering if people can actually feel the difference, like corresponding to those the map changes, like the hypoperfusion that's on that left-hand side of the brain, whether they feel it before and then they feel, I mean, a lot of the people that I work with feel a lot more relaxed afterwards. Does the brain actually register that in the body?
Well,
I think that's the correlation.
This particular person did not feel it. In fact, he did not know he had that slow focus until I pointed it out. Most of the time it's benign, and one of the characteristics, because of the location it has in the brain, is that it affects speech. You know, it's Broca's area. And when I asked this person, do you find yourself having tip of the tongue phenomena, forgetting your words, things like that, he says, yeah, that happens to me a lot. In that way, behaviorally, they can feel it. Physically, most of the time, no. And again, he didn't know until I pointed it. I said, well, I think it's a good idea for you to get an MRI, you know, because it's ischemic. We just need to make sure that your brain, there's nothing structural in the brain. He went to get an MRI. MRI turned out to be completely fine. It would be interesting as a second answer to your question. It would be interesting to see whether his tip of the tongue phenomena would get better.
Yeah, that's
And
interesting.
again, the obstacle we were facing at the time, and we still face, is it's pretty much funding. We to be able to collect more longer term data, we need the money for it. Now, with me being here in Singapore and with me having my colleagues now and the ability to have more than one EG amplifier, we're going to reduce a lot of that overhead. And once the COVID situation gets better resolved, we hope that we can test more people and collect more data and have more follow-ups, because I'm going to be here for a couple of years, and therefore we're going to be able to collect data and do follow-ups and answer the questions that you're asking us in much more detail.
So do you, in terms of, as I say, a lot of the clients that I do work with, once we found the activation, they are highly activated. And then afterwards they feel much, much calmer. So have you worked with anyone that you've actually seen that in their brains and that change with the EEG?
Yeah, and actually I'm going to show you the next EEG to show you what it was like. So
thank you.
I wanted to open up my camera to answer the question, and I'm going to turn it off and I'm going to share my screen. All right, so here we have actually 3 EEGs here: baseline, during brain spotting, and after brain spotting. So I'm going to open the baseline, and let's do this first. I'm going to open after brain spotting and the baseline. So on the left we have baseline, and then to the right we have after brain spotting. Now, the question that you were just asking can be somewhat answered here. This is one of the individuals that participated in the research, and this is a transgendered individual, somebody with a lot of anxiety. If I remember correctly, they had been working with Deb Antinori for anxiety, depression, and some OCD type behaviors, if I'm not mistaken. Now, we're going to focus on 2 regions of the brain. This one called FZ, mainly, and FZ is the anterior cingulate cortex, is the frontal midline in the middle, so it's the ventral medial prefrontal cortex. And what I want to show you is that this individual has a lot of activation in that area during baseline. So just make a mental note of this type of activity here. Okay, this is the baseline. So that's at rest, not doing anything. And you are going to see that they do have a lot of activation in the region. So this is rumination, this is fretting, this is cognitive inflexibility, this is anxiety and depression. So it's one of those markers or those networks of the brain that correlate with the symptom presentation. And again, the session was 45 minutes long. Don't remember what setup was used. I think we mostly use outside and inside window. I could be wrong. I would have to check the notes for that. Again, activation in the anterior cingulate cortex. So lots of activation in the anterior cingulate cortex. And again, the client came in quite highly overwhelmed and anxious and depressed. I mean, that's the ongoing salient feature, symptomatic presentation for them. That's what we had before brain spotting, and this is what we have after brain spotting. And I'm going to pull up the PowerPoint because I have the images from that individual, so I can show them to you. Let me share my screen again. And I think you can see them. Okay. Please confirm that you can see the PowerPoints.
Yes, we can see it.
Okay,
Yeah.
thank you. So this is before, and the red, purple, orange spots show the activation. So this is the activation of the anterior cingulate cortex and the right temporal lobe. This points more to fear, anxiety, agitated depression, rumination. And then we also have high activation of the posterior region of the brain. So this is sensory hypersensitivity, perceptual hypersensitivity. It's a brain that is having a hard time, struggling to cope with the stimulation. This is before. Okay, so the more purple, the more yellow, the more orange you have, the more overwhelmed that brain is. And this is after the 45-minute session. So again, before and after. This is not only the brain responding better. This is the client saying, "My gosh, I feel so much calmer. I feel better. I feel relaxed." Look at the reduction in the activation. The greener, the better. There's still some activity going on, mind you, some yellow, little residuals of the yellow here, still a little bit on the left temporal lobe, but for the most part, look at the activation in the anterior cingulate cortex, in the perceptual and sensory regulation regions of the brain. And after 45 minutes of brain spotting, that's what happens. Now, again, we cannot say that this is going to sustain unless we measure it and we do long-term follow-up, but it's very exciting to see that after 45 minutes, we have a brain on fire, a person overwhelmed with anxiety, with depression, with fretting, and then after 45 minutes, we can give them the chance to regain some control.
Santiago, may I ask a question?
Yes, of course.
Do you have any measurements where you can compare the effects of brain spotting versus the effects of talk therapy?
No. Anything that that you may and everyone may ask me about brain spotting versus this versus that. I don't have any data because we did this initial recording. We were planning on doing some more, and then the pandemic hit. So COVID has really slowed everything down. It's just put us on, it's just put everything on standby. One of the things we discussed with Dr. Jessica Joel after we had our session last week is that we need to come up with ways of comparing brain spotting to other forms of intervention, counseling, and CBT, even EMDR. And this is not to compete; it's just to show that brain spotting can be equally as effective, and it can be effective on its own. So hopefully once we're past the situation here in Singapore as well, we can again get together and develop more formal research. We have the technology, we have the population, and we have the knowledge. But unfortunately, anything you ask me about brain spotting versus this or that, I cannot answer at this point. So I apologize for that. Now, any other questions or comments before I continue here?
Yes, can I ask a question, Santiago?
Yes.
I notice often and this happens like when we're way in the process already, and that the client says, the back of my head hurts. And it's interesting for me that, because it can go into so many different places, but particularly this location seems to come up quite often. So I was really curious about what happens then in that moment when the back of the head starts hurting. And as we continue the processing, usually it will flow out and it will go somewhere else. But I don't know, can you speak to that a bit?
Well, what I think is happening is that different people have different physiological components and different neurophysiological components that are a little more developed than others. And therefore, they are more sensitive to experiencing a reaction in those parts of the body when it comes to the processing of the trauma. Why? I think one is genetic, and two is the environment. You know, in trauma, as in mental health, the question that lingers the most is it nature or is it nurture? And it's both. So when you're working with somebody who's traumatized, you have to look at their upbringing, you have to look at their genetics, and you have to look at their physiology. And you try to match that to the environment. I do believe that there are people who respond in certain areas just because those regions are more sensitive. Why? I mean, you know, I could give you, and my colleagues could give you many hypotheses. We really don't know. But I do believe that some people are born with certain areas of the brain or certain parts of their body that are more sensitive to that respond more in a more sensitive way to trauma or pain or processing. That's what I could tell you. Other than that, again, we just need to do more research to learn more. This is really scratching the surface. I mean, and it's barely scratching the surface as far as the knowledge goes. But we got to start somewhere. You know, we cannot keep us from doing more research.
Would you say that if the back of the head starts hurting, it becomes activated, and is it therefore then you have not enough blood flow to that region? That there is
it could be that you don't have enough, or it could be that you have too much.
both.
And the only way you can know that is by looking at the EEG. You cannot know that by just looking at the person's face. You need some kind of objective measurement. But I think that's why EEG is so important.
Okay, thank you.
Okay, so let me show you, and then I'll stop here for more Q&A and comments. Some of the slides that I have been able to produce from some of these EEGs. So let me share the PowerPoint here. Okay, and I think that you can see the PowerPoint. Now, it could be that we can see quite the opposite when we're working with somebody. In this case, we have low power in the alpha band in the posterior region of the brain, and that means the thalamus might be dormant. I'm using dormant for lack of a better term, and I think that probably is the most appropriate term. The thalamus is not communicating the subcortical brain to the cortical brain. We need that yellow peak in the back of the brain to be higher. Okay. Now, after brain spotting for this individual, there's an increase in the alpha power, in the alpha band, and you can start seeing that the amplitudes of the frequencies in other parts of the brain also go up a little bit. So I think that brain spotting can also, through the visual field, reach the thalamus, and via the processing that the person experiences, it wakes the thalamus up. And therefore, we have a better communication process between the subcortical brain and the cortical. Now, all of the images that I'm showing you are after one session. So it's exciting, yes. It's promising, yes, also. But we have to just be cautious about how we take this information. As we get to do more consistent measurements, I think this will show up consistently over time. And we can compare it to other forms of intervention. We can compare it to medication. We can compare it to neurofeedback. But this is one of the individuals, and I thought that was very interesting in that their alpha was not responsive, their thalamus was not responsive, and then we got it to be more responsive. This is a 3D image of the frontal ventromedial prefrontal cortex. So this is the anterior cingulate cortex, and this is red. So the red, the circled area correlates with anxiety, rumination, depression. And after 45 minutes of brain spotting, you can see a reduction in red. So it means that there's more regulation of the anterior cingulate cortex, a reduction in the anxiety, reduction in depression, reduction in rumination. This is a very good Loretta image. Loretta is the software that shows the images, and you can see the red areas activated for this individual. So anterior cingulate cortex, ventrolateral prefrontal cortex, insula, amygdala, cuneus, precuneus, all areas relevant to the default mode network, salience network, and negative effect network. This is baseline, and this is after brain spotting. Look at the difference. Less red is better. And these are not the same individual. These are 3 different individuals. So these images correspond to 3 different individuals. So we have some initial data, which again looks promising, but we need more research. We not only need more research, we need more people to do more research. And I know some of us are going to start getting together to come up with better ideas. What's exciting again is that now I'm based in Singapore now, because when I was in Colombia, I was one of 2 people doing Brainspotting. So 2 people out of 50 million. It's kind of hard to do it. Now, there's a large group of brain spotters being trained and constantly learning, and we have the technology here. So my colleagues and I here are very, very excited about what the future holds for us. We just need to be patient with COVID for things to settle down, and then we can start doing something. With that in mind, I just want to thank you for your attention and your stamina. I want to open the room for more questions in the comments or any additional criticism that you may have. All is welcome.
Okay, sorry, Santiago, can I ask another question?
Of course.
So I was just really curious. So when you were talking at the beginning, you were talking about you talk about the mid-range when people can. What are you talking about at that point? Like they can process better, or they're not so stuck, like up hyper or hypo? Is that
right.
What's happening?
Yeah, what I was referring to is called perfusion, meaning blood flow to the brain.
Yeah.
The brain will either go into hyperperfusion, it gets excess blood flow into an area, stroke, hemorrhage, an injury. But the brain can also get hypoperfusion, reduction in blood flow to the brain. The consequence of a traumatic brain injury, the developmental lag in the brain, poor connectivity, poor nutrition, inflammation. And then we also have neutral positive perfusion, which is the right amount of blood flow to the brain. Perfusion, it's very important to brain function, because when you get blood flowing to a specific region, you bring in glucose, you bring in oxygen, and you bring in a lot of other nutrients that the neurons need to function very well. Now, so what it means is you have hypoperfusion, you're going to have reduced function, low motivation, problems focusing, problems remembering. If you have hyperperfusion, you're going to have some other sorts of issues. So what we need to have is the right amount of blood oxygen going to the brain at a specific moment.
And so can I ask, because I'm really intrigued, because I actually did share on the last training with David that I can actually feel things in my body as what's going on for people. And what I've found is, and so I'm wondering if this is in the moment as well as like longer term. So for example, if you're brain spotting with someone, if they're better off, for example, to go with Robbie's training, she calls it the resource spot. But I've done some training with Mark Grixty, and he uses lots of pictures. And I found that if I put people on a higher spot, like in the room, like one which gives them some energy, which I'm wondering if it's then corresponding to, if they're too hyper aroused, it gives them a sense of this, bringing them more into that mid-range. Because in my body, I find that when someone can't process something, I begin to yawn. It's like I'm like an extension for them to release, or it comes into me and I have to release it. And then when I give them enough energy, it enables them to stay in this point where I don't need to yawn, and I start to burp and sigh. So I can very much feel that when someone gets too far down, particularly, that, or probably too far up as well, but I can balance it out. And I'm just wondering if that corresponds to processing with people on their resource spots, or does that make sense?
It could very well be. That's a very good question. I think one of the aims with this kind of work is to be able to help brain spotters hone their skills much more efficiently, in that it helps you understand your client's window of tolerance more profoundly, and you can work within that window of tolerance. You can know how far you can push them either way. Again, it could correlate with it, but we don't have enough data to support that. I believe that happens, from a hypothetical point of view. I believe it's related to what you're saying. However, as we get better with the measurements, we'll be able to tell with more certainty.
Because that's what I was wondering, is whether that relates then back to the perfusion being hyper, that we can actually see that on the EEGs. Yeah,
you could see it in the EEG. If you're recording, you can see where they're going. Yeah. And it's situation specific, and it's probably processing specific. Different processing at different moments during the trauma will change blood flow to the brain. Sometimes clients will have more, sometimes clients will have less, sometimes clients will have the ideal. And it's different for everybody. That's the tricky thing about this, is that no two brains in the world are wired equally. So because everybody's brain is unique, it makes the work that we're trying to do that much more challenging.
Yeah.
Thank you very much. Are there any more questions for Santiago before Santiago shares a little bit about the full day workshop that he'll be conducting in July?
I'm just wondering if Santiago would mind to share the slides today, or it's private and confidential.
The pictures, the pre and post pictures.
Yeah.
Yeah, I'd be happy to share with those. All I ask is that you credit my work in them. That's absolutely fine.
Yes.
Thank you.
We've recorded
very much appreciate it.
We've recorded this session as well, so we'll share the recording of the session with you once it's uploaded.
Thank you. Santiago, I have a question about specifically those types of trauma that's related to physical abuse, where the client is like the aftermath of, let's say, like a really bad damaged back, for example. They are relating the physical pain that they're experiencing right now with the trauma. I'm just wondering if there's anything specific, like brain region wise, that's kind of might be active. Just curious about.
Yeah, normally when you have really severe trauma and it borders with PTSD, or you have a diagnosis of PTSD, normally it's the right posterior temporal lobe that gets more activated. Sometimes in EEG, you see one single yellow peak in the alpha range, and that's a biomarker. It's a clear biomarker for PTSD. And I've seen it quite often in severe physical abuse. Yeah, when I was back in Colombia, I had the opportunity to work with several women who were victims of rape, sexual assault, and I would say 9 out of 10 had the biomarker for PTSD. So with the EEG, we can definitely identify some biomarkers for PTSD, and that's going to be useful because that helps us direct the way we conduct the brain spotting session. I think it can help the brain spotter hone their skills and do the scans in such a way that we're getting as close as possible to those networks.
Yeah. So I'm wondering, like, if it might be more accurate for them or more helpful for them for me to like brain spot their physical sensation or their physical pain. Wondering if that's going to activate those regions.
I think it will. I think it will, because after all, brain spotting being a neuroexperiential process, most of our clients process not through speech; they process through physical manifestations of it, and the relationship is there. So I think that it would be quite useful for you to focus on the sensation at some point. Yeah.
Thank you.
You're bridging the gap more efficiently, I think.
Thank you.
All right. Any final questions? If you have a lot more questions, then we invite you to join us for the full day workshop that Santiago will be conducting on the 3rd of July, which is a Saturday from 9 to 5 Singapore time. And Santiago, would you like to share a little bit more about what we can expect from that full day session?
Yes, yeah. Well, we're very excited because we're going to be able to speak in more detail about the EEG. However, it's not going to be an EEG specific workshop. What we're going to talk about is we're going to talk a lot about the neuroanatomy of trauma. So I'm going to be focusing more on the networks I was mentioning in the beginning. I'm going to be talking about how trauma affects and interferes on brain networks. So how does the cognitive system, the sensory system, the emotional system, et cetera. And I'm going to be showing some examples from brain recordings as to why that happens. But the focus will be on lots of neuroanatomy, so that you as a counselor, as a brain spotter, as a psychologist will benefit from learning a lot more about the brain. You will gain knowledge that you didn't previously have. We're also going to focus on psychophysiology. And one of the topics I'm going to be talking in great detail about is going to be heart rate variability and how the heart impacts brain activity. So why it is important as brain spotters for you to understand the autonomic nervous system, not only from a brain perspective, but also from a heart perspective. And I can point you to gadgets, very cheap gadgets that you can use to train heart rate variability to enhance the brain spotting experience with your clients. So again, we're going to talk heavily about brain networks and neuroanatomy. We're going to talk about psychophysiology. And I'm also going to talk about neurobiology. I'm going to be mentioning how different neurotransmitters and chemicals in the brain interfere with dissociation or hypervigilance, and how those relate to the brain spotting experience. So a lot of the work we do is going to go back to how it relates to brain spotting. And again, you will benefit in that you will get new insights into neuroanatomy and neurophysiology. You will learn about heart rate variability and how you can implement it. Okay, and there's a question here. Yeah, I use the heart math, Robbie. So I can show you the heart math and other gadgets, how you can implement heart rate variability. We will talk about temperature and skin conductance and how you can use very cheap equipment to use in your practice, to measure, or even to use alongside with brain spotting. So it's going to be a full day. We will look at some EEGs and brain scans in more detail, but again, to discuss networks and neuroanatomy and how it's involved. So it's going to be a fun day full of new knowledge that you did not previously have, with some practicums as well, some practical demos as well.